Welcome to the session on drug allergy. My name is Josh Boyce, and I will be moderating. After my brief introduction, we'll hear three separate 10-minute presentations from experts, followed by 5 minutes for Q&A following each of the three presentations. Why do a session on drug allergy? First, I think from an allergist perspective, this is the problem that keeps us involved with the inpatient side at the hospital, by far the leading indication for an allergy consultation. And it's a very common problem. We define drug allergy based on an adverse drug reaction that has an immunologic basis, or a type B reaction, which distinguishes it from a reaction that is based on the pharmacology of the drug. So, for example, somebody who gets an upset stomach with erythromycin has a type A reaction rather than a type B reaction. It's quite a common problem. A meta-analysis conducted in 1998 by Lazarou in JAMA revealed that about 15% of all hospitalized adults either were admitted due to an adverse drug reaction or experienced an adverse drug reaction during their inpatient stay. And of these, 39% were judged to be life-threatening, and virtually all of those were type B or immunologic true allergic reactions. And with increased longevity of patients with chronic diseases, we see increased prevalence of drug allergy due to repetitive exposures and the effect that that has on sensitizing the immune system to antibiotics, chemotherapeutic agents, and more recently, biologics. Drug allergy is important because it incurs substantial healthcare costs and also limits first-line therapeutic options. And as allergists, we face several challenges. The diagnostic tests have limited predictive value, or in some instances are non-existent. The mechanisms of drug allergy are sometimes poorly understood. And there is also a limited availability, not at the Brigham, of course, but a limited availability of clinicians with expertise in the area. So today we're going to hear from three clinicians with expertise in the area, beginning with Dr. Tanya Laidlaw. Tanya directs our aspirin-exacerbated respiratory disease center here at the Brigham. She's also the director of translational research in allergy, and she's going to tell us about nonsteroidal anti-inflammatory drug reactions. Tanya.
Thank you. So this is the story of a disease that was frustratingly ignored for a very long time. So aspirin-exacerbated respiratory disease, or AERD, which rolls off the tongue a little better. I see it as a biologic puzzle, a biologic mystery, that I think if we work hard enough to understand and are creative about our research endeavors, we might actually be able to fit in the last few pieces of that puzzle to end up solving it. So I'm going to sort of think about this in four different ways, four different sections for the talk. First is, what is the disease? What does it feel like to have it from a patient's perspective? So we can give you an attempt to know what it feels like. Secondly, go back in time to kind of my brick wall slide. What had been the barriers to progress in the field? What had made it so frustratingly delayed in its progress? And then how are we breaking through those barriers? How are we hurdling over those problems to try to solve them together as a team here at the Brigham? And then go through some of the science. What was known? What have we added that's known now? How can we use that science, that basic science, to then push the field forward and make new discoveries that will have real therapeutic applications for our patients? And how is our science doing that? So AERD presents in your 20s, 30s, 40s. So a completely healthy patient who has perhaps no history of asthma or allergies at all develops asthma at the age of 24, 32. Out of nowhere, and then develops these things called nasal polyps, which are growths within the sinus cavity that completely fill your nose and your sinuses and behind the eyes into the forehead. You block airflow in and out of the nose, completely ruin sense of smell and taste. And then you develop these classic respiratory reactions to aspirin, so that even low doses of any medication that inhibits the cyclooxygenase 1 enzyme, aspirin, ibuprofen, Aleve, things available commonly over the counter and commonly used to treat things like fever and pain that we don't even request a doctor's information to take those medications ourselves, cause these reactions within about 30 minutes to 2 hours after taking them. The disease is treated by pulmonologists, by ENT surgeon specialists, and by allergists, and yet either despite all of this fancy tertiary care, or maybe even because of disjointed communication between them, we end up with really embarrassingly delayed diagnosis. So our team looked last year through all of our database information and found that there was an 11-year average delay between the onset of nasal polyps, the beginning of the disease, and when they were actually diagnosed with the disease. 11 years. And this is a disease that has 3 distinct characteristics that my granted quite brilliant and hardworking coordinator who's worked for 4 months can now diagnose over the phone. It's not that hard to do it well. We as a field were failing. So this is Danielle. And she's a patient I met when she was about 35. There was, I think unfortunately for the field, nothing unusual or unique about her at all. She was one of the most classic cases of AARD I'd ever seen. She was completely healthy as a child. Just after college, when she was 23, she got what felt all the world like a bad cold, upper respiratory infection. She didn't even seek medical care for it. But the cold persisted. The fevers went away. Those initial symptoms were gone, but she was left with constant nasal congestion. Within a year, she developed real asthma, and she had never had it before, and she continually stayed congested. She lost her entire sense of smell, and with that, almost near sense of taste. She saw an ENT surgeon within a year. He looked up her nose with fancy cameras, saw that she was completely full of polyps, and very appropriately did a polypectomy, a polyp surgery. She almost 2 or 3 days later felt great. She could breathe through her nose. Her asthma was better. But within less than 6 months, they were all back again. It was as though the surgery had never happened. So in that same time frame, she took an Alka-Seltzer, a little ironically actually, to try to improve her nasal congestion. And within about an hour or 2, she started sneezing. She got some chest tightness. She was wheezing. She used albuterol. She didn't even recognize the connection between the Alka-Seltzer and the reaction until later. Alka-Seltzer has a full aspirin in it. Not necessarily known, because when we think of the brand name, we don't necessarily think of its ingredients. 3 months later, she took a couple of ibuprofen for a bum knee. And within, again, 1 hour, she had a similar reaction, but this time the wheezing was so severe it did not go away with the albuterol she had at home. She ran through her entire albuterol, called 911, needed albuterol nebs and IV steroids in the emergency room to break through that reaction. Still did make the connection between a medication she had taken all the time in college for her bum knees and had no problem. 6 months later, she took an Aleve. Same reaction. So now, finally, she had a good physician on her team, and they put the whole thing together, and they realized what was going on. So at the age of 25, actually not that delayed in diagnosis, she was properly diagnosed with having the classic triad: asthma, recurrent nasal polyps, and these respiratory reactions to 3 different COX-1 inhibitors. Despite her very appropriate diagnosis, she didn't do very well. She had a repeat surgery when she was 27. She took a little break from surgery for a couple of years while she had 2 kids. She had a repeat surgery at 33, another one at 35, and I saw her a few months later. Her polyps were already back. She was on 7 medications a day, constant sinus infections, and had still maintained a total loss of sense of smell. And I had this underlined, the sense of smell, to remind me that although the medical morbidity is pretty obvious from severe asthma attacks, from near-fatal aspirin reactions, from constant need for surgeries, despite all of that, it's often this one symptom that bothers our patients the most. So for all of the parents in the room, you know that sort of sweet, sour, cuddly baby head smell that you want to snuggle with and hold tight because it's so warm? She has 2 kids and she doesn't know that smell. She's never once smelled her children. And her friends would tease her, wasn't that nice, you didn't have to smell the dirty diapers. And she's always quick to point out that there was a dangerous downside to that too. She has on no less than 2 occasions fed her children spoiled food. She's fed her 9-month-olds completely rotten baby food. She sampled it, she smelled it, seemed fine to her. She did not know it was rancid. That's how lost her sense of smell is. So we don't know much about this disease. It is not a classic IgE-mediated reaction to aspirin, the way reactions are to peanuts or to ragweed pollen. It's not classically inherited. Her mom didn't have it. Neither of her 2 kids will necessarily have it just because she did. It's not a childhood disease. We don't know why. There is no obvious infection we found that causes it. There's no obvious environmental toxin we found that causes it. And once you have it, it is permanent. So when she got it at 23, she will have it when she's 83. It does not go away. So the respiratory disease is almost always severe. Certainly the nasal polyps are very aggressive and very recurrent. The asthma is usually severe as well. And these cells called eosinophils, which are immune cells, are in very high levels in the tissues of the sinuses and those polyps, and in the lung biopsy tissues, and also in their blood. We don't know if those eosinophils are causative of the disease or not, or what role they play, but there are a lot of them there, and there must be a clue within that. So if there wasn't enough of a mystery presented in the disease, there's yet more to the mystery. So very low doses, 40 milligrams, like half of a baby aspirin, will cause the respiratory reaction. But these patients are amenable to desensitization. So we give them slowly increasing doses of aspirin every couple of hours, and we get them up to tolerating close to 650 milligrams twice a day, 4 aspirin a day. And we do that because we have a 70 or 80% chance of actually improving their symptoms. Those high doses of aspirin in 70 to 80% of patients will delay their polyps from growing back, will improve their sinus disease, can improve their asthma outcome, and in a few very happy patients will bring back and maintain their sense of smell. And it's a lot more common, as it turns out, than it had been thought. So around 7% of patients, adult patients with asthma, which estimations would lead us to a little over 1 million patients in the United States. It is not that rare. So this is my sort of science slide. We need to know where we were to know what we are to go forward. So this is a slide of the metabolism of arachidonic acid and the metabolites that we know are likely involved in this disease. So on the right-hand side are the production of leukotrienes. On the left-hand side are the COX enzymes, that COX-1 enzyme I spoke of. So the production of leukotrienes, we have known since the 1990s to have problems because patients with AERD are known to overproduce leukotrienes at baseline and to further overproduce them during these aspirin-induced reactions. Leukotrienes are involved somehow. In order to make leukotrienes, your body needs 2 separate enzymes in a row. So first 5-lipoxygenase, the 5-LO at the top, then LTC4 synthase to make LTC4, which is exported out of the cell. You end up with LTE4 as the end metabolite. We measure that in the urine. We see lots of it in ARD, and we see like explosively higher quantities of it during those reactions. We've known 3 things from previous research. 1, they overproduce them, more LTE4. 2, that LTC4 synthase enzyme seems to be overexpressed in bronchial biopsies of eosinophils. So maybe the enzymes there are a little messed up. And 3, this receptor, the cis-LT1 receptor, is likely to be overexpressed in the tissues as well. So there's sort of pieces of that side of the pathway that we know are wrong. On the left-hand side, we know something's wrong with the left-hand side because if you block COX-1, frankly, all hell breaks loose for these patients. We need to figure out what it is. Downstream of those enzymes are the prostaglandins, PGE, D, I, F, and thromboxane. We don't know which one of them is so important that when it's changed, that's what causes the reaction. But what had been known is that these patients appear to produce a little bit less PGE and have lower EP2 levels. And that seems to mean that they're less likely to be able to block 5-LO. So maybe that explains a bit of the circle. We don't know which cells make leukotrienes. We don't know which cells don't make PGE. We don't know which cells have more or less of which receptor. We have no idea why it's specific to patients with AERD. So this is the brick wall slide. This is what had been in the field's way, which is pretty much everything about the disease, to make progress. We were terrible at diagnosing it. Oral challenges can be dangerous. Few hospitals in the country are willing to do them. There was very little education about the disease. Patients themselves didn't know that they had it. We didn't know the epidemiology of how frequently it was, how it was found, how to find it. I've already showed you in one slide how much science was known about the disease. We had no specific molecular targets we wanted to treat, and without that, we had no pharmaceutical interest in trying to make it better. We had nothing to offer. So in the last 8 years since I've been here, we've started to push in many directions, and I'm going to give you 2 kind of dorky science slides that we've been able to do in terms of the science, and then tie that into how we're changing the field. So we found these tiny little cells called platelets attached to other cells in patients' noses and blood. So up here, these teeny little red guys are actually tiny platelets in the microscope that in the nasal polyp of a patient with AERD are attached to these regular immune blue cells. They hadn't been known to be there. They're much more commonly attached, much more frequently attached if you have AERD than if you don't. In the blood as well, these eosinophils and several other cells we looked at, in the patient with AERD, 76% of that woman's eosinophils had platelets attached to them. Much more than if they were aspirin tolerant. And it turns out that wasn't just an observation, it mattered. We found out that the addition of these platelets onto it adds the extra enzyme, that LTC4 synthase enzyme. And we know that if we take the platelets off the cells and then stimulate them, they make much less leukotriene. So we know that the platelets can contribute to all this leukotriene production, and we can at least blame the platelets for part of that. We've also found that that platelet activation increases during reactions, hinting at what might be going on in the reaction. The next thing we found out had to completely differently do with that science slide with PGD. I mentioned all the leukotrienes go up. That seems important. Here they are at baseline. Here they are going up. But here you are 2 months later on high-dose daily aspirin. I told you it made you feel better. Your polyps haven't come back. You feel great. But your leukotriene levels are not at all lower than they were beforehand. But you feel good. So that isn't the answer to what the high-dose aspirin is doing. It turns out that in parallel, on the other side of that science slide, is this PGD, prostaglandin D, previously sort of ignored. also high at baseline compared to controls, also increases during reaction. But this time, decreases way down when you're on high-dose aspirin, back down to sort of what normal levels would have been for a non-AARD patient, perhaps hinting at the sort of causes of the reaction and of the mechanism of aspirin. And so we end up with two big orange things that we can add onto it. Platelet aggregation, leukotrienes, platelet activation, hint to reaction, PGD reaction, and maybe even decreased PGD. Explains what we're doing with our high-dose aspirin. So these are the ways that we've hurdled over our barriers. Education, websites, outreach, international conferences. We have a bioinformatics approach to diagnosing this through the computer. We are standardizing aspirin desensitizations and challenges with our center. We have carefully designed clinical trials that have outcomes and monitoring with them, sort of keeping that dorky science true to our hearts to make sure that as we have discovered platelet activation, how can we take that into the patient to understand what's changing with the trials that we're doing. With Josh's help, his lab has developed a mouse model for testing hypotheses that we can do for preclinical work for clinical trials. And with all of that together, we've had the opportunity to do a ton of industry outreach and get pharmaceutical companies interested in treating the disease with good medications. So what we can offer now, streamlined process for evaluation and diagnosis. We have the largest patient registry in the world. Lots of aspirin desensitizations, 10-fold more than there were when we started. The use of medications that we now understand their mechanism and are able to use them more frequently in our patients. 2 ongoing clinical trials with 2 new medications based on the work that we had found. But we need a lot more to continue to push the science forward. We have 150 patients. We need thousands. We need many more. We have biomarkers we're looking at. We need more ideas. We are going to scale up the bioinformatics approach, see if we can help other hospitals do the same thing. And we're going to continue to work at this understanding the mechanism, right? So yes, we have some platelets. Yes, we have this PGD idea. We need more than that. And to do that, we need to work continually to get this sort of collaboratory, right? Collaborative work in between the direct accessibility of the clinicians and the researchers and the patients for sort of triangle to go back and forth to decrease the life cycle, shorten the life cycle between the medical discovery and the accessible treatment for the patient. And I'm pretty sure we will be able to add in some more pieces to this puzzle. Thank you. So I'm happy to take questions if there are any.
Please.
Wondering if you could expand on what's the interaction between the platelet and the white blood cell. Is it a non-specific binding, or is it for, do you know at all if it's to some certain receptor?
Sure. So the platelets attach to the white blood cells through an adhesion receptor called CD61. And so CD62P. So when they become activated, they express this adhesion receptor and attach onto immune cells. And so by virtue of activation, and the activation piece is relatively nonspecific. A lot of things that activate a platelet will get them to glom onto an immune cell. But once they're attached, we know that the addition of that extra enzyme that platelets have can increase the production of leukotrienes downstream. Thank you.
So our second speaker this session is Paige Wickner. Paige is the Director of Quality and Safety in Allergy here at the Brigham. And she's going to talk about an approach using the electronic medical record to identify patients with drug allergy.
Thank you. So as Dr. Boyce mentioned, I'm going to talk about how we are tackling listed drug allergies in our electronic medical record. I want to start by giving a little bit of background onto this issue. So penicillin allergy is the most common drug allergy. It affects 10% of our population, probably some people in this audience. 15% of our inpatients here in the hospital are affected by penicillin allergy. And half of our hospitalized patients at some point during their stay receive antibiotics. So this is a really wide-reaching problem that we face today. Those patients who have a listed penicillin allergy in their medical record face a lot of burdens. They receive increased broad-spectrum antibiotics for their treatment. They also have increased rates of healthcare-associated infections at rates that I've listed here. So C. diff, VRE, MRSA. These patients additionally face increased mortality, increased ICU transfers, larger costs of stay that are for both the patient and the hospital system that they're in, and they have really worse outcomes for their infections being treated. Okay, so lots of implications for the patient. We also know from multiple studies in the field that penicillin allergy disappears around a rate of 10% per year. So in studies where they test and then they challenge the patient with a penicillin, 90 to 99% of those patients are no longer allergic. Okay. So to bring this home a little bit to the Brigham and sort of our data and how this is playing out here, we really have similar numbers to those that I just told you. We have about 220,000 patients who have a listed allergy to penicillin in our electronic medical record. Okay, and this is data that I got through David Bates's group and our collaborations. That's around 10%. We spend a lot of money on alternatives to penicillin, vancomycin, aztreonam, quinolones, only some of which is appropriate. We also know, as I mentioned, that for our patients and our organisms that we have, unfortunately, in our patients at our hospital, this treatment is not always the most efficacious. So Pseudomonas, right, an infection that can be lethal, is more effectively treated by penicillin relatives, ceftazidime, cefepime, than it is by an often used alternative as aztreonam. Okay, and the numbers are listed here. So I want to share with you two scenarios as we sort of go through this talk for you to think about. The first, who wants to come up, is the case of a 65-year-old male who has a listed penicillin allergy and is admitted here for a fever and back pain. He's failed 6 weeks of an alternative antibiotic, despite the fact that he has a known penicillin-sensitive abscess. He has a listed penicillin allergy. His reaction is listed as hives. It happened over 50 years ago. Okay, so keep him in your mind. The second one is a 68-year-old male who has prostatic hypertrophy, transitional cell carcinoma, and has had frequent admissions for urinary tract infections, who also carries a listed penicillin allergy. He has had 16 admissions, 15 emergency department visits in the past year. For these admissions and visits, he has received multiple courses of antibiotics, including linezolid, levofloxacin, vancomycin, despite having pan-sensitive organisms, so organisms that could really have any antibiotic. He has no idea what his reaction to penicillin was. This is very common, okay? Around 70% of our listed allergies in our EMR say unknown. He was told by his parents that he was allergic as a child. So we were fortunate enough to obtain funding to investigate this issue from BCRISP. BCRISP is Brigham Care Redesign and Incubator Startup Program, and for those of you interested in care redesign, we'll be talking more at 3 o'clock in the innovation side of things. And we decided to work on this problem here at this hospital, approaching sort of a study with 3 arms to try to figure out what is the best way that we can deal with these patients and optimize their care, their antibiotics, and costs. So the 3 arms are baseline. So patients, we just sort of collected standard of care. What's happening with these patients? Many of them receive alternative antibiotics. Some people have allergy consults. Some people are given antibiotics despite their listed allergy. The second arm was skin testing. And basically what we did was take patients who are admitted to medicine, placed on antibiotics, who have a listed penicillin allergy, and test them to see if we can delete their allergy. And we have a 90 to 99% chance of doing so, as I told you guys already. And the third arm, which I want to describe in a little more detail in the next few slides, is a clinical pathway. So this clinical pathway is an algorithm that was developed by our colleagues and collaborators at Mass General in both infectious disease and allergy. And it's been a pen and paper format to date. But what it does is it guides the provider, not necessarily the allergy specialist, through a series of questions in order to safely prescribe a penicillin or a penicillin relative for the majority of patients. Okay, so I don't have time to go through sort of all the questions here, but what you see is you bucket patients into these categories, and then it tells you sort of what you can offer your patients safely and sort of how to do it. Okay. And what this pathway does is it really shifts the care of the patient from using these sort of expensive alternatives to drugs that are really more effective for the patient, reduce hospital-associated infections, mortality, ICU transfers, et cetera, and cost the system much less money. So the drugs that are decreased with the pathway are on your right, okay? And you can kind of take a look at all the numbers. We have both the acquisition cost here at the Brigham and the average wholesale price, and we make a shift to the other side where things are much more cost-effective and providing better care. So we've completed the baseline patient collection. We've also completed our skin testing arm, and we had about 1 patient who had a positive, which is pretty consistent with what I told you about the 99% rate of clearing the allergy. And we are about to embark on a very exciting next step in taking this pen and paper pathway that's been in place at Mass General and implementing things here at the Brigham in an electronic platform. So we have developed an app. We also have a website, and we have partners' clearance and approval for clinical decision support integration into Epic to utilize this pathway to really both harness data, collect data and information that we can use to understand this issue and guide providers on what to do safely and effectively, okay? And we actually also recently got approval to roll this out and spread this concept at all 5 partners' hospitals. So that's an exciting other test of change we're going to be doing. And so really what it's all about is improving value, right, in all these arenas for the patient. And if we talk about our 45,000 admissions that we have here at the Brigham every year, again, 15% of whom have a listed penicillin allergy, and half of whom are treated for infections. If we can reach and affect therapy in even half of those patients, we will see significant outcomes in all of these arenas, including cost, which is about $2 million per year for the hospital. So, you know, it's always about the patient. I want to make sure we think, you know, as I finish up my short time here, about those patients I told you. And these were 2 patients who had presented during our skin testing study period. So I want to tell you what happened to this gentleman who had 6 weeks of alternative therapy that was failing. So he came in. Our team tested and challenged him with penicillin. He was among the 99% where things were negative. His listing was deleted from the electronic medical record, so forever and ever from now on, he's very likely to be able to take penicillin and penicillin relatives. His abscess was treated with an alternative course of therapy and improved and resolved. The second patient, who had 16 admissions, 15 emergency room department visits, lots of alternative antibiotics, same story. We tested him. We challenged him. His testing was negative. He was able to receive alternate therapy. His listing was deleted, and our wonderful research coordinator contacted him recently, and after we looked through sort of his records, 0 ED visits or admissions since then, which is just a really, you know, impressive impact of care. So, you know, I think that this is an issue that we all face with the universal mandate of electronic medical records. There's a wide impact in terms of the patient volume and numbers of patients, and we have this unique opportunity here at the Brigham to make a real improvement on how we as a field and how we as a hospital system manage these issues. And so we're really looking forward to the challenges ahead and to spreading these concepts both here at Partners and elsewhere. And I thank you so much for your time and your support.
Time for some questions for Paige.
So much. Do you ever find that a patient, like how much information do you give them when you're planning to treat them in this new way? And are they ever resistant? Like, I have an allergy, don't do it?
Yeah, so you mean with the clinical pathway?
Yes.
Yeah, so the clinical pathway patients, so we have not started the clinical pathway arm here at the Brigham yet, but their experience over at Mass General has been very positive. The administration of the penicillin or penicillin alternative is usually done in the form of what's called a challenge, and we didn't have time to sort of go over the details of the pathway today, but what that is a little bit more nursing attention during the time you're getting the challenge for about an hour to sort of assure safety. And so I think the response has been really favorable. It's actually been in place in a pen and paper format hospital-wide there since 2013 without really any hiccups or roadblocks, and they found no different rates of reaction in terms of drug reactions than baseline.
Thank you.
Please.
Do you think that there'll ever be a time where you'll be testing all the patients that have penicillin allergy documented before they need the antibiotic?
Yeah, so I think that's a really good question. So the question was, you know, will you be testing patients prospectively before they need the antibiotics? I will say that in my own practice, and I know in the practice of my wonderful many colleagues here at the Brigham, I always encourage patients who have a listed penicillin allergy to come in and have testing, because what I say is that, you know, I'd rather test you now when you're feeling well and we're here in clinic than the consult that we often get, which is this patient's not doing well acutely from some perspective, and oops, we really, really need a penicillin at this point. So, you know, do I think it's realistic that we're going to test all 220,000 patients patients prospectively? No, but I think we do need to think about ways to streamline, especially high-risk populations, and test them before their bone marrow transplant, their surgery, all those things somehow in the future. Thank you.
Thanks. So our third speaker today is Dr. Mariana Castells, a longtime colleague of mine. Mariana directs our drug hypersensitivity and desensitization program here at the Brigham. And she's truly the world's expert in this area. We're very fortunate to have her here, and she's also one of the bravest physicians I've ever encountered. She does things that I would never do.
Thank you, thank you very much, Josh. I'm delighted to be here and share with you some of the things that we have actually done here with all my colleagues, actually. I'll bring you to a little bit of a different field in terms of talking to a little bit about more complex patients. We're talking here about patients who have cancer that, because of the wonderful treatments that we have now for cancer, that survive longer and they're exposed to multiple chemotherapy treatments. And also about patients who have chronic inflammatory diseases, rheumatoid arthritis, inflammatory bowel disease, psoriasis, who are now treated with those wonderful monoclonal or biological agents, and those also have increased their quality of life. So we are talking about patients who really benefit from those medications, and even cystic fibrosis patients who actually live longer, have long transplants. And we have seen now an increase in what we call drug allergens. So chemotherapy, monoclonals, antibiotics, and as Tanya was mentioning to you, aspirin, are considered now to be drug allergens. So I'm going to just play a couple of scenarios to actually make sure that we focus on the topic of the desensitizations for those high-risk patients. So this is a 49-year-old female with a BRCA-positive ovarian cancer, and she's treated initially with paclitaxel and carboplatin. And in the last cycle, she says to your doctor, you know, I feel a little bit flush, itchy. The doctor said, be okay, take a little bit more Benadryl. And then she's fine because she is now in remission, but she recurs 2 years later. And she's restarted on the Taxol, paclitaxel, and carboplatin. And on the second infusion, again, this is her AIDS exposure. She's flushy and itchy. She tells her doctor, and the doctor from an outside hospital said, well, we'll be fine. We'll give you more Benadryl, more steroids. These things happen to everybody. And then in her third infusion, 9th exposure, then she really doesn't make it. Cramping, abdominal pain, flushing, and she's short of breath, and they don't have time to reach, her IV push, and she's hypotensive, and she codes, and here is the big mess. And so they called, and I recommended, why don't you get a tryptase level? Tryptase is the product of the mast cells, and actually you can make the diagnosis of anaphylaxis, the most severe of the allergic reactions, by just drawing a tryptase level. And the normal range, which I omitted here, is 11.4, so she had 4 times more tryptase in her blood. So she was truly anaphylactic. And she's brought to us, to the allergy team, and we do skin testing. That's the one way we have to assess if that would be an ongoing allergy, and she's very positive. So what do we do with this lady? We avoid the carboplatin. The carboplatin is what had put her in remission last time. So do we really want to avoid that? So we know that the risk of carboplatin hypersensitivity is pretty high when patients are exposed for a long time. So you see here bolded in red that when there is 8 to 9 exposure, up to 20% of the patients will become allergic. So that's a big number, particularly for those women with ovarian and breast cancer who are exposed to their good chemotherapy for a long time. And they might go into 2, 3, 4 cycles. But also what we have known in the last couple of years is that the BRCA, you have the red here, indicates that the patients who have those BRCA mutations are at much higher risk. You have the upper part is the ones that don't have it, and here the downside slope means that after 5, 6, 7 exposures, there is a much higher population of BRCA carriers that will become allergic. So we are in the right population. But we know also some things, and the some things that we know in our desensitization center that we have been doing is that we just submitted this year for publication, and the patients who are desensitized to carboplatin actually, when compared to patients who have no allergy and who have not been desensitized to carboplatin, have not presented that reaction, they actually seem to either survive longer whether it's because they are back on their first-line therapy or because the immunological things that are ongoing when you're allergic kind of help the cancer. We have no idea, but this is the data. So it is to the patient advantage to be back on her carboplatin. So here we are now switching gears. We have a monoclonal antibody, infliximab. This is a wonderful monoclonal antibody. We have a lot of patients who get remissions instead of getting surgeries for their rheumatoid arthritis. And this is a 25-year-old male with severe rheumatoid arthritis. And he has been treated on any medication. And when he gets on infliximab, he gets a remission. She has tremendous good mobility, good quality of life. But on the 10th infusion, 15 minutes into that, he's itchy, back pain, he feels not good, and then they continue the infusion with a little bit more of Benadryl and a little bit more steroids, and he has hypotension. So he codes, he's given epinephrine, steroids, Benadryl, IV fluids, and he really nicely recovers. So infliximab is discontinued. Of course, you have a severe reaction. High doses of steroids, methotrexate, he is put on everything in the book. He develops insulin, he develops diabetes, hypertension, he's obese, and has osteopenia when I meet the patient. So what we do, we just do a skin test. We do the infliximab skin test, and he has a very positive infliximab skin test. So what do we do with this patient? Do we avoid that, or should we actually try to do something to put the patient back on this infliximab? And the rate of the hypersensitivity to monoclonal reagents that we have available, even the humanized monoclonal reagents, is about from 1 to 10%. So this is a real problem. So we know now that the symptoms of hypersensitivity reactions are coming from our big friend, the mast cells. So when mast cells get activated through either Ig and non-Ig mechanisms, they release the histamine, tryptase, which we talked about, leukotrienes, prostaglandins. And the symptoms that you have in the right side are that the patients have cutaneous symptoms, the pink. Everybody gets itchy, flushy, hives. And then they also can have cardiovascular symptoms. As we were saying before, prostaglandins, leukotrienes, and histamine can decrease blood pressure, open holes in the blood vessels. We can also have respiratory symptoms. The patients become very short of breath, can have throat tightening, gastrointestinal symptoms. And one of the things that are new to us is the red bars, which you see here, neurological muscular symptoms. Our patients have pain, back pain, crushing chest pain, pain in the pelvic area. And when we do x-rays and EKGs, it's completely normal. We do troponins and it has nothing. So there is a mediator of hypersensitivity that we have not uncovered yet that can induce pain in those reactions, whether that be bradykinins or kinins, as we see in hereditary angioedema. We are speculating about those. So what we decided to do is to provide a model in vitro to actually be able to desensitize the patients. And what I show you here is that in the first figure, in the tall black bar, we have, and I think maybe I have, yes, the mouse. So if we give mast cells in vitro an antigen that's called DNP, we can have them release histamine or beta-hexosaminidase. But if we give that instead of, those are the individual doses, but if we give that in cumulative doses, those little things here, the mouse mast cells do not release that beta-hex or histamine. So we kind of learned that in vitro, we can happily turn off the mast cells. We also know that the cells that are activated need calcium, and this is the blue here. But when desensitize those cells, the cells are actually in red here. The calcium doesn't enter those cells. So we have now a model in which what we call a rapid desensitization that blocks the release of those preformed mediators and the calcium flux, and that is in a specific fashion. When we desensitize those cells here and they don't release, they don't have the calcium entry, but we have another antigen like OVA, the calcium enters the cell. So it's a very specific process. So if we were to desensitize somebody, as Tanya was saying, to aspirin, and the patient is allergic to penicillin, we could not give penicillin to that patient. So it's a totally specific patient. So the principles of the desensitization, and now we know, occur at the membrane level. And we have established in vitro how do we want to start those desensitizations. So we have here a mast cell that is resting, then it's sensitized with those little IgE in the membrane, in the receptors. And then the antigen comes. And what would happen is that after the antigen comes, everything is internalized, and then there's a release of the mediators. When we desensitize those cells in vitro, the antigen, the Ig receptor, the Ig and the IgE receptor stays at the membrane. So what we know is that the desensitization inhibits the skin test reactivity in previously sensitized patients by blocking this internalization. What we have done based on the in vitro protocols is we have designed protocols at the Brigham, 4 bags or 3 bags. Those are the protocols. So instead of giving a medication like paclitaxel or carboplatin or infliximab in 1 bag, we have now 3 to 4 bags depending on the severity of the reaction of the patient. And if we dilute 10, 100, and 1,000 times more that. So I just wanted to point out that we have drugs that we have successfully desensitized listed here. We are the biggest center in the United States, but also in the world about drug desensitizations, aspirin, but also monoclonals and chemotherapy. All those things can be desensitized and have been desensitized. Platin, staxins, monoclonals, antibiotics, even enzymes, iron, aspirin. And our latest project is for women who have infertility progesterone. The safety of this in the initial description was unprecedented. We had no deaths, and all the cases can have mild or no reaction. And we just submitted 2,177 cases, again with 96% mild, no deaths, and 4 severe reactions only. And all the patients were able to finish their desensitization. And I don't want to bother you, how do we do this? But we evaluate the patients for drug hypersensitivity by doing skin testing and deciding on desensitization based on the risk of the patient. We use tryptase, as we said now, to assess the extent of those reactions. And the future and the discovery that we need to push is to find out better skin testing for those patients. We don't have skin testing for every patient who has reacted to every medication. We also want to do that in vitro. Instead of doing that in the patients and exposing them again to the drug, can we take their blood, and we have work ongoing into identifying specific IgEs or basophils, which are surrogate markers for mast cells. And we also are looking and very actively working on the targets for the in vitro, and we have some potential candidates, STAT6 and SHIP1. So I leave this here, and thank you very much. Yes, sorry.
Time for questions for Dr. Castells.
Thank you, Dr. Castells. It seems that one of the problems you might face would be to spread awareness about this. Specifically, you talked about a kind of a difficult situation where people give steroids and then it turns out to be a real reaction. How are you kind of starting out with that problem?
Yes, that's a great question, because the fact that we do it here doesn't mean, that we're spreading the rest of the world. We have teamed up with the National Cancer Institute through the Dana-Farber, and I'm a consultant for their new guidelines in terms of what happens with the patients who, first the gradation of the reactions, and then changing the wording. They used to call those reactions toxic reactions, and a toxic reaction means there's nothing we can do about it. So right now we are putting the word anaphylaxis on those guidelines and saying, if the patient has what we call a grade 3 anaphylactic reaction, an allergy consultation would be indicated. And we'll leave it there. But definitely getting the word spread is what's the next mission.
Please.
Does this method of desensitization have a role in the desensitization in food allergies?
That's a great question, and I think our colleagues, Dr. Jessica Savage and our colleagues are working very actively at food desensitization. This model is not being replicated in food allergens, but potentially could be used since when I showed you the mast cells. Ova is in a food allergen, so this could be totally applicable to food desensitization.
You mentioned
mentioned that up to 20% of patients who receive carboplatin 8 or 9 times develop these reactions, either with carboplatin or other chemotherapy reactions. Is there anything else you found that could help you predict which patients are going to start getting a reaction in order to head that off before it happens?
Yeah, that's a great question, Tanya. And so what we've started to do is we started to do HLA typing of those patients. We think that it might be genetically determined that some of those patients might, the same way that the BRCA determines an increased risk for those patients, it is very possible that there is an HLA, and we already have some preliminary data on that. Thank you. That's a great question.
How about atopy?
Yeah, that's a very interesting question, Josh. So we have found that in our initial paper with Anna Feldwig, about 30% of our taxol allergic patients had atopy. And we have actually in our cohorts been replicating that with the platins also. So in our last cohort of 2,177 cases, about 42% are atopic. So it definitely. But because atopies are like polygenic, is it IL-4 gene or is it any other? Yeah, but definitely there. So going back to Tanya's point, if you have a patient who is receiving chemotherapy and is allergic to anything and everything, that might be a high-risk patient for developing those chemotherapy reactions or monoclonals.
Okay, so if there are no more questions, that concludes the session. Thank you for attending.